Good evening, everyone, and welcome to the Schwarzman Animal Medical Center's 10th Annual One Health Conference, hosted by the Anne and Charles Johnson One Health Institute. My name is Rachel Lordahl, resident veterinarian in oncology at the Animal Medical Center, and I will be moderating tonight's event. This is day 5 of our conference, where we are exploring a comparative approach to cancer diagnosis and treatment. After tonight's talk, we will take questions from the audience, which can be submitted through the chat box. And as a reminder, at the end of the event, please click the link in the chat or scan the QR code to submit your form for CE credit. Tonight, we will be discussing the comparative oncology and translational aspects of common cutaneous tumors in human and veterinary patients. I'd like to thank both of our speakers, Dr. Anna Pavlick and Dr. Margaret Wong, for joining us tonight. Anna Pavlick is a medical oncologist with over 20 years of experience treating patients with skin cancer, including melanoma, basal cell cancer, squamous cell cancer, and Merkel cell carcinoma. She is also an expert in treating ocular melanoma, eyelid tumors, and other rare solid tumor malignancies, including a research interest in neurofibromatous 1 malignancies. Dr. Pavlick was recruited to Weill Cornell Medicine as professor of medicine in the Division of Hematology and Medical Oncology. She is the founding director of the Cutaneous Oncology Program at Weill Cornell Medicine and New York Presbyterian. Dr. Pavlick's major research interests include investigating targeted therapies, combination therapies, and immunotherapies. She also conducts outcomes research evaluating quality of life. Dr. Pavlick earned her medical degree from the University of Medicine and Dentistry of New Jersey Robert Wood Johnson Medical School, her Master of Science in Human Anatomy from Fairleigh Dickinson University, and her Bachelor of Science in Biology and Nursing degree from Fairfield University. She completed an internal medicine residency at Robert Wood Johnson Medical School and hematology and oncology fellowship training at Memorial Sloan Kettering Cancer Center. In addition to her undergraduate and medical training, Dr. Pavlick graduated from the Drexel School of Medicine Executive Leadership Program in 2012 and earned her Master of Business Administration degree from Columbia University Business School in 2017. Dr. Pavlick has authored and co-authored over 100 publications and presented her research at international meetings. She serves on the several editorial boards, including the Journal of Drugs and Dermatology and the Journal of Immunotherapeutics of Cancer as the associate editor. She is a member of leading oncology societies, including American Society of Clinical Oncology, American Academy of Clinical Research, the Society for Melanoma Research, Society for Immunotherapy and Translational Research in Cancer, and the European Society of Medical Oncology. Dr. Margaret Wong received her doctorate in veterinary medicine from Washington State University College of Veterinary Medicine in 2001. This was followed by an internship in medicine and surgery in 2022, as well as a specialty internship in oncology in 2023, both at the Schwarzman Animal Medical Center. Dr. Wong is currently a resident in medical oncology at the AMC. Thank you, Dr. Pavlick and Dr. Wong, and we look forward to hearing your talks tonight.
Thanks so much, Dr. Lordahl. I'm going to start off tonight and I'm going to introduce everyone to some veterinary cutaneous tumors. So let's begin. So as you can see here, this is a huge topic. There are a lot of tumors here, and humans and veterinary patients share many of these tumors alike. Two of the most common tumors that we see in both species here, the canine and the feline, are mast cell tumor, as well as squamous cell carcinoma. I'm going to focus on these two tumors tonight. Although humans do not develop cutaneous mast cell tumors like their veterinary counterparts, the roadmap for drug development of this tumor and possible treatment overlap is why they will be included tonight. So as you can see here, we're going to start off with mast cell tumor, and these are canine mast cell tumors. And cutaneous mast cell tumors in the dog can come in many different flavors. This image here on the left of your screen is how some of them can look fairly benign, right? They're usually raised, round, freely movable, and they can have variable erythema. This image here on the right looks more ulcerated. This patient actually has a recurrent cutaneous mast cell tumor located over the scar of a previously excised tumor. And sometimes they can bleed, weep, ooze, depending on if they're actively degranulating or not. It's pretty often that we'll hear owners discuss that, oh, the tumor was there last week and then it went away for a few weeks and then it came back, almost as if it's like a hive. And that tends to happen because these tumors release histamine. And so they can be there one week, go away the next, and then come back with a vengeance. Very variable how these tumors can look. These are two more images of mast cell tumors, and this is that same dog you were seeing from the previous photo. Here he's having a degranulation event, and you can see that we have patches of erythema. In some cases, edema can be associated with the skin when the mast cell tumors look like this. They can take on these like rash, plaque-like forms, and degranulation can also be extremely severe. So on the right-hand side here, this is a cutaneous mast cell tumor that unfortunately degranulated after it underwent a surgical biopsy. And this poor patient had mast cell infiltration into the epaxial muscles there, as well as disease infiltration into the rectum and the descending colon. So these tumors can look like they are just affecting the outside of the body when you're initially examining them, but actually can have infiltration into the deeper tissues. So diagnosis and staging. Generally, these tumors, they're first investigated with fine needle aspiration of the primary tumor. Not all tumors require pre-medication with Benadryl and steroids prior to aspiration, but it can be extremely helpful, especially if you're nervous that the tumor looks like it's angry or could possibly have a degranulation event. In that case here at AMC, we'll oftentimes use a 25 gauge needle, which is enough usually to be able to get enough cells from these tumors because they exfoliate very, very well. Um, Even if the tumor is oozing or weeping, sometimes we can just make impression smears of blood that's coming from the tumor in order to get a diagnosis. So it doesn't have to be like a very aggressive sampling of this tumor because they exfoliate so well. If you do plan on giving steroid after aspirating, I think consideration should be given to drawing a circle around the tumor where you aspirated because steroid can actually retract these tumors quite a lot. And oftentimes they'll present to have surgery performed, and after being on steroid, the tumor has become much smaller. And so that can be really helpful, as well as taking pictures of the tumor. And then, of course, before removing any tumor, we always want to investigate any draining lymph nodes. These can include lymph nodes that are on the periphery of the body, that are palpable, but can also include lymph nodes that are inside the body. So doing an abdominal ultrasound and investigating those lymph nodes, especially the medial iliac lymph nodes, if we have a lesion that's on the hind limbs, and then consideration of aspiration of the liver and spleen, especially if we're nervous that this could potentially be a higher grade tumor that may have already metastasized. We want to know that information before we go to surgery. We'll often say we should do thoracic radiographs beforehand, and it's not necessarily because these tumors metastasize to the lungs. It's more so because these tumors can sometimes not be the only primary tumor, right? So we want to make sure that we're making sure that this patient is a healthy, good anesthetic candidate before going forward with surgery. And so, once we've removed the tumor, the patient's prognosis and treatment are dictated by the histologic grade of the tumor. And there's currently two grading criteria we use together in mast cell tumors. There's the Patnick grading scheme, which is the 1, 2, 3 you'll see in the histology reports, and the Kupel, which is the low grade and the high grade. And you can see here I pulled this Sabatini paper from 2015. And putting these two grading systems together actually tells us that these tumors can behave in a pretty aggressive way when we separate the grade 2 tumor. So grade 2, high grade, and grade 3 tend to have abbreviated survival times. And that bottom graph there shows you the probability of survival at 12 months was 95% for low grade mast cell tumors and 24% for high grade mast cell tumors. And the median survival time really isn't reached, right, for these low grade tumors, while it's 150 days for these high grade tumors. So there's a very big difference here, and the grade helps us to understand what we should be recommending to the client. We also know that a mutation in the KIT receptor at exons 8 and 11 can give us information about response to treatment with the drug Paledia, as well as prognosis. So, when available, histopathology of the draining lymph node as well can help to direct us as to how we're going to treat these patients. So surgery is generally the treatment of choice. We should always be looking, and I'm gonna say this with quotes, to cut to cure, because it's pretty rare that we do cure something, but we always want to approach these tumors as if they're a grade 1 or a low grade tumor. And take margins that allow us to cure a patient if we're surprised when we take them off and we get that. And so at AMC, we ideally like to have 5 millimeter margins for these tumors, but of course, we'll get more if we can take them. And surgery, of course, provides us with two things: cytologic reduction of this tumor and also the histologic grade, which we just talked about. So what do we do when we get histopath back and the report says it's a grade 2 high grade or a grade 3? The recommendation is to follow up with chemotherapy. And you can see in this paper by Webster et al., published in 2008, these are the survival curves of dogs with grade 3 mast cell tumors treated with surgery alone or with postoperative chemotherapy. And you can see that those who are treated with postoperative chemotherapy tend to have a longer survival time than those treated with surgery alone. Now, each patient's different. Maybe the tumor's in a location where we can't get appropriate margins and it comes back as a grade 2 high grade and we have dirty margins, or the tumor can't even be removed. Paledia is a tyrosine kinase inhibitor that was created and developed for treatment of mast cell tumors. And this drug is an oral medication that can be used in the setting of gross disease. And we'll often turn to it when we do have evidence of gross disease or metastatic disease that's present in these patients. Radiation treatment is also an option. It's a follow-up option when we have dirty margins, but it's also a treatment that we can utilize for gross disease. There's new papers out of Italy in 2021 that have shown some promising results with electrochemotherapy in these tumors. And then, of course, the introduction of Stelfonta. So Stelfonta is a drug that's injected directly into the tumor and essentially reduces blood supply, necroses the tumor, and then the tumor sloughs off. We are not using this drug here at AMC yet, and one of the reasons we're not is because we really need that histologic grade to give us information about how we should be following up with these tumors, and unfortunately, Stelfonta doesn't really give us that if we're using that as the first-line treatment without biopsy of these tumors. And then Gilvetmab, this is a brand new drug that's on the market. This drug is an immune checkpoint inhibitor. It's one of the first of its kind in veterinary medicine. And we're going to get more into this drug later, so I'm going to skip over this for now. So now mast cell tumors in cats. These behave pretty differently than they do in our canine counterparts, and they look very different. So you can see here there's kind of this plaque-like lesion. They can sometimes be a little puffy, a little erythematous. They're usually pretty small. They can be broad-ranging and flat. You can see this close-up of a cutaneous mast cell tumor on the face of a cat here on the right-hand side. It almost looks like it's a tiny little pimple. It's white, usually not bothersome to patients, but again, can have these variable appearances. And then the behavior and staging of these tumors is quite different. So there's two distinct types of cutaneous mast cell tumors in the cat. Which the more typical is the mastocytic mast cell tumor. It's histologically similar to mast cell tumors in dogs. And the less common type is this histiocytic form. These mast cell tumors, they may regress spontaneously over a period of 4 to 24 months. In contrast, these ones that are histiocytic or have this more anaplastic uh, population of cells, these can have a high mitotic index, marked cellular and nuclear pleomorphism, and infiltration in subcutaneous tissues. And even so, these can sometimes behave in a more benign manner than the cutaneous lesions we see in dogs. Siamese cats appear to be predisposed to development of mast cell tumors of both histologic subtypes, and cats with cutaneous mast cell tumors should be evaluated for evidence of additional cutaneous and splenic tumors. So if you find one, you should search through the coat to look for other tumors because the likelihood of them having more than one mast cell tumor is high. And it's not uncommon for us to see that cats who have cutaneous tumors do have splenic involvement of their disease as well. So the treatment of choice here, again, surgery whenever possible. And we see here in a series of 32 cats with cutaneous mast cell tumors, 5 cats developed local recurrence after surgical excision, although none of the cats in this study died of their disease, which is, unlike their canine counterparts where we see that these tumors can behave pretty aggressively. And so remember how we said test the spleen? That comes into play here in some of these cats. And it turns out cats who had splenic involvement and had splenectomies had resolution of their cutaneous tumors. And that's the graph that I'm showing there on the right. So we can utilize steroids in times where we cannot take these tumors off, and it may help to quiet these tumors down and quell some of the inflammation and irritation that's associated with them. And we can also use Palladia, both for the systemic involvement, if, say, splenectomy is not an option. And we've seen some pretty prolonged survival times with just Palladia and steroid. If we're having refractory disease or disease that's spreading despite using steroids and Palladia, maybe the cat already has had a splenectomy, then we can look at systemic chemotherapy, and we're often looking at utilizing vinblastine. Sometimes with local disease, if we have one tumor and it tends to be bothering the kitty, we'll do triamcinolone injections. And although not common, we can use strontium for these tumors. So now I'm going to move on to canine and feline squamous cell carcinoma, and I've kind of lumped these together instead of separating the two species. So these are malignant tumors of the epidermis. They tend to happen in older dogs and cats, so approximately 10 years of age or older. They have a predilection for the head and neck, but they can really be anywhere. You can see here on the right-hand side of the screen, this is a dog. It's a close-up of his chest, but he has had a previous squamous cell carcinoma that was removed. And on recheck, this is the scar line, and you can see that there are these crusted lesions popping up to the right and left of the scar line, and that's actually disease recurrence. And so these can look plaque-like to papillary. They can be erythemic, ulcerated, crusted. The cat at the top with the nose, we just did a little punch biopsy there to help us get a diagnosis, but it's not uncommon for them to look ulcerated like that. The cat on the bottom here, that's his little cute paw, and you can see there he's got some crusted lesions, and those lesions are squamous cell carcinoma. So variable appearance. Staging, we always want to look at local lymph nodes again. If we're looking at the head, we should be aspirating bilaterally. And these tumors have a tendency to metastasize to local lymph nodes, to the lungs. So thoracic radiographs, if we're considering something more advanced, because we're going to do radiation treatment planning, CT of the head, thorax, abdomen is usually the way to go. And so the treatment for this is, varied and depending really on infiltration of the disease, right? So surgery, when we can get it, is the best case scenario for these animals, and we want to do an aggressive surgery from the start. So we're looking at something like a nasal planectomy when the tumor isn't involving the deep tissues associated with the nasal planum. And you can see here, this cat on the bottom has had a nasal planectomy, and unfortunately, this cat has disease recurrence there. But the prognosis is very good in cats after surgery with nasal planectomy. In one study looking at 61 cats with squamous cell carcinoma, local tumor recurrence was reported in less than 10% of cats with a median disease-free interval of 594 days. So quite a long time, and 426 days for cats with multiple locations. And that's with surgery alone. The prognosis after nasal planum resection in dogs is generally good, and it really depends heavily on whether or not we can get good histologic margins with the first surgery. Radiation treatment has been utilized for these tumors, but really discouraging in dogs with local recurrence reported in virtually all patients, with median times to recurrence of 2 to 3 months. And then cats treated with ortho voltage, the 1 year progression free survival rate was 60%, and the median disease free interval for 55 cats treated with mega voltage was 361 days to 916 days. Strontium physiotherapy is also an option, and this is the application of radioactive strontium directly to the nasal planum. And this treatment is primarily indicated for cats with superficial and minimally invasive squamous cell carcinoma. So we're looking for patients who have invasion of up to only 3 millimeters because the strontium doesn't penetrate that deep into the tissue. So in two studies, the reported complete response rate was 88%, with local recurrence reported in 20% of cats, and the median progression-free interval of 1,700 days, with 3-year disease-free rates of 89% and 92%. And you can see this kitty at the top is undergoing strontium therapy, and the cat we saw in the last slide, this is his little paw after receiving strontium, so he's just healing here. I think his little fingers look so silly. And then, of course, cryosurgery. There's a brand new 2023 paper that looks pretty promising for electrochemotherapy in dogs, and this was a prospective study, and it's looking at dogs following surgery, and it found that dogs had a 32% higher survival rate when using than when using the surgical approach alone. And then I just wanted to include here these patients can look really cute. I think it's very hard for owners to, do a nasal planectomy because everyone wants to boop their animal's nose all the time. But I would argue that, these patients have the best chance of having long-term survival with these surgeries. I still think they look pretty cute. So next, I'm going to move on to the comparative oncology aspect of things. So why did I choose these specific tumors, and where are we going from here? So one of the things Dr. Pavlick is going to talk to us about very shortly is immune checkpoint inhibitors. And these are very commonly used in human medicine, and unfortunately, we're just lagging behind in veterinary medicine. But generally speaking, and this is very general, these drugs allow our immune system to work more effectively at killing tumor cells by allowing the immune system, the T cells, to interact with the tumor. So Gilvetmab, this is the only veterinary approved immune checkpoint inhibitor. It targets PD-L1, which is the programmed cell death ligand. And it's labeled for dogs with stage 1, 2, and 3 mast cell tumors and stage 2 and 3 melanomas. And the drug trial showed that most patients with mast cell tumors had a partial remission or stable disease, whereas melanoma, it seems like it's less effective, with stable disease achieved in approximately 40% and less partial remission and complete responses. And so where are we going? And one of the things that I think veterinary medicine is lagging behind with is mutational analysis of tumors. So we don't really understand our tumors the way that our human counterparts do. And so we don't really have a lot of targeted drug therapy available. And so I just want to touch base on one of the most studied and best described molecular mutations in veterinary medicine is the receptor tyrosine kinase KIT of mast cell tumors. Um, the activation of this receptor tyrosine kinase leads to cell survival, proliferation, and motility through multiple intracellular signaling pathways. Ooh, I knew that was going to happen. My light went out. Um, I'm sorry, I'm in the dark. A 2021 paper essentially showed that prognostic parameters in canine cutaneous mast cell tumors with exon 8 and 11 mutations were commonly associated with a high proliferative activity and poor prognosis, while prognostic markers in canine cutaneous mast cell tumors with mutations in exon 8 had lower values similar to those described with without the mutations in exons 8 and 11. So the discovery of this KIT mutation, it really led to the creation of Palladia to treat these tumors. And although humans don't have the same type of mast cell disease as canines, they have a better understanding of their KIT mutation, which is specifically an exon 17. So I feel like there's a lot of room for us to overlap here and learn from what they've done. And the same thing with squamous cell carcinoma. I know that Dr. Pavlick's going to go through some of the molecular landscape of these cutaneous tumors in her talk. And we don't actually know a lot about ours. So we've had a few studies that looked at P53 in cutaneous squamous cell carcinoma. And it revealed that 30% were positive for P53 overexpression. But without knowledge of the mutational landscape of these tumors, the creation of targeted therapies has essentially been non-existent. So we have a lot to learn from our human counterparts. I'm hoping that, you know, we will start to generate more information about how our tumors behave, why they behave in these certain ways, and what drug targets we can utilize. I want to end here with this little clip from a recent paper, and it's utilizing feline patients as a model for oral squamous cell carcinoma drug development in humans. And so, you see our veterinary patients suffer from similar malignancies as their human counterparts. And I think there's a real opportunity here for advanced discovery in both species by continued collaboration. And that's it. I'm going to pass it over to Dr. Pavlick now to talk to us about cutaneous tumors in humans.
Okay, let me share my screen. Okay. Are we good? Everybody can see my presentation. So I really want to sincerely thank you for inviting me to speak with you tonight. And I absolutely agree that there's so much that we can learn from one another to help improve animals as well as humans. And so I'm going to talk tonight about human non-melanoma cutaneous malignancies. Since you all have a session in melanocytic tumors, I decided to leave melanoma out of my talk tonight. So when we talk about human malignancies, I'm sorry. we basically talk about basal cell, squamous cell, and Merkel cell cancer. These are the most common tumors diagnosed in humans in the United States. And as you can see, basal cell, hands down, is the most common. Fortunately, basal cell is also one of the most indolent tumors that's out there. So it's easily managed with surgical excision or a Mohs procedure done by a dermatologist, followed by squamous cell carcinoma. And then you can see melanoma, however smaller in number, clearly the most deadly. So this is one of my favorite slides. Since the advent of tanning salons, cutaneous malignancies have skyrocketed, especially melanoma, which has an increase of almost 75% incidence with just one episode in a tanning booth. All of these tumors in humans are directly caused by UV exposure, especially excessive UV exposure. Patients who have fair skin, blonde hair, blue eyes, especially those who have strawberry blonde hair and freckles, are at an increased risk of developing cutaneous malignancies. There's also some genetic predisposition, especially with melanoma, for patients who also have pancreas cancer in their family. We look at what's called a P16 deletion, which is responsible for both pancreatic as well as melanoma in families. Patients who also have weakened immune systems, such as those patients undergoing organ transplant, as well as those who have low-grade lymphomas, whose immune systems are suppressed because their lymphocytes are not functioning properly, are also at an increased risk of developing cutaneous malignancies. So I really think that this really speaks to why our cutaneous malignancies, melanoma included, are so sensitive to immunotherapy. Because these lesions are all induced by excessive UV exposure, these tumors, as you can see in this box here at the end, that's colored in pink, are the lesions that are UV damaged, and that UV damage causes significant mutational abnormalities. And the higher the mutational burden, the more sensitive the tumors are to immunotherapy. And so you can see that number one is squamous cell, Merkel cell, and melanoma up here. Okay. And now I can't move my slide. Okay. So let's talk a little bit about squamous cell carcinomas. And although this is the second most common skin cancer, it is a cancer that is, again, caused by UV damage, which causes DNA damage. It can present as red patches, open sores. These are tumors that are very, very curable when identified early. Surgical excision by a dermatologist is most common in these lesions. However, when these lesions become larger and more ulcerated, these patients are referred to surgical oncologists and would undergo a wide local excision and many times even a sentinel lymph node in order to determine if there's disease to the nodes, which would then indicate that these patients would need adjuvant immunotherapy. I like to think of all of these malignancies, particularly the cutaneous and basal cell cancers, as cancers of neglect, for the simple reason that these cancers grow very, very slowly. Many times they happen in elderly who are in nursing homes or folks who have little or no insurance who then just let things go because they just can't afford to get good care. These things grow over years and certainly not over days to weeks. And you would think that when these lesions are so slow growing that getting locally advanced or metastatic disease would really be quite unheard of. But again, due to the neglect that occurs or the immunosuppression that some of these patients have, we do see locally advanced or metastatic squamous cell as well as basal cell. The treatment for both squamous cell as well as basal cell, and I'll have a very similar slide for basal cell, is really a multidisciplinary approach. Many of these patients never get to see an oncologist or a surgical oncologist. If they are identified early, they're identified by a dermatologist, and they are surgically excised by a simple excision or a Mohs surgery. These patients do not need imaging. They don't need oncologic follow-up. However, the larger the lesions, the more fungating the lesions, the more aggressive the lesions. Many times, these patients do get referred to surgical oncology as well as medical oncology. Squamous cell is also a tumor that can invade the nerves in the surrounding area, which we call perineural invasion. And those are patients that are referred for radiation therapy, since many times they can metastasize along a nerve and patients will get a nerve palsy, indicating that there's neural involvement. For tumors that are either unresectable or resectable with positive margins, or perineural extension that is just not resectable or in a radiation field, patients get referred to medical oncologists to consider. In the past, we used to consider chemotherapy. We used to consider EGFR receptor inhibitors, namely cetuximab, which do have very high response rates in the 40 to 50% range. However, these options are not durable, which means we'll get control of the tumor, but within somewhere between 6 and 9 months, the patient's tumors are going to progress and you're back to square one. Fortunately, we now have immunotherapy in our toolbox. Agents such as cemiplimab or pembrolizumab demonstrate a better than 50% response, and 40% of that 50% will go on to have complete tumor responses that are in fact durable. So really something exciting in our world. And if you look over at these photos, this is a gentleman with multiple squamous cell carcinomas. And again, this is a large fungating lesion on the back of someone's ear. And here you can see here, after just 6 weeks of anti-PD-1 agent cemiplimab immunotherapy, there's near complete resolution of all of the man's cutaneous lesions, and there's a healing of this gentleman's wound as well. This is actually one of my patients. She's an elderly woman who was living at home. Hard to believe that nobody noticed this. But when you spoke with her family, they said, oh yes, this was a lesion that developed over years. The patient had Alzheimer's disease. She was very agitated and aggressive, and the family felt it was almost impossible to get her to a dermatologist. When they finally did, the dermatologist performed a biopsy, which came back as erosive and invasive squamous cell carcinoma. Imaging demonstrated this lesion eroded into her skull bone. And so, being deemed unresectable, she was sent to me to see if there was anything we could do for her. I offered her anti-PD-1 therapy. She did receive pembrolizumab. And here you could see the time point here after just 1 month. The lesion is significantly better. Here's 2 months. The lesion has healed over. Subsequently, she went on to have a complete and durable response. She got approximately 6 months worth of immunotherapy and never had to be treated again after that, with 0 toxicity. And that's something that's also interesting, is that most of these lesions, basal cell or squamous cell, really do occur in the elderly population. And many of these patients have excellent responses, but yet no toxicity. And what we've come to learn is that many times their T cells, the effector T cells that will cause toxicity, become exhausted as patients get older. So it becomes very easy to treat these patients because they get the benefit of their tumors regressing, but they don't have to deal with some of the potential side effects of immunotherapy. And this is just a swimmer's plot to show you that although treatment stops, the durability of the responses continue. And quickly, we'll talk about basal cell carcinoma, most common type of skin cancer in human beings, 3.6 million diagnosed. Again, very, very common, easy to manage when identified early. Happens most commonly in skin-exposed areas, especially the head and neck. Much higher frequency in men, on the ears, on the scalp, on the nose, especially on the scalp, since many men have balding as they age. They don't think to ever apply sunscreen to the tips of their ears or their scalp, and subsequently the development of skin cancers. And you can see here, they can occur in lots of different ways. Here's a lesion here that's much more nodular. This is much more ulcerated. And this can even masquerade as a melanoma, since it looks like it's irregular with irregular borders, very large and pigmented. And this is actually a basal cell cancer that started at the external aspect of the patient's eye and continued to eat directly into his orbit. So treatments for basal cell very much are like the treatments for squamous cell. It's a multidisciplinary approach. Many of these patients never, ever get to see an oncologist or a surgical oncologist because they're treated by the dermatologist or the dermatologic surgeon in their offices. We do have a topical cream called imicramod, which is a TLR9 agonist. It's an immunotherapy cream for low-grade or very small lesions, especially in patients who you may not want to operate on. It is not good for larger lesions or much more aggressive lesions. Radiation therapy can also treat basal cell, but again, many of these patients are elderly, and getting them to and from radiation for 6 weeks in a row, because again, it's every day, Monday through Friday, for about 6 weeks, is also a hardship for many patients, and they opt not to pursue that. So in that event, many of these patients then make it to the oncologist if this is something that's not resectable or large or disfiguring. Our first line of therapy, which was FDA approved approximately 15 years, is a hedgehog inhibitor. It targets the patched and the smoothened pathway. These are the pathways that basal cells use to metastasize. They are present in 99% of all basal cell carcinomas, so it's not a mutation that we need to even test for. If a patient comes in, it looks like they need to have systemic therapy, we can offer them either vismodegib or sunitinib. Both of these agents are oral. They're taken once a day. However, they do have some untoward side effects that do affect the elderly population, which can sometimes be a little bit worrisome. If these patients are not tolerant of hedgehog inhibitors or progress on hedgehog inhibitors, they can be then offered immunotherapy with cemiplimab. So this is, again, showing how hedgehog inhibitors work. Again, just a comparison of vismodegib and sunitinib. Both basically have the same efficacy. And the next slide is really just to show you what some of the toxicities that we worry about in the elderly are. Number one is really the dysgeusia. It's the bitter taste. They lose their taste buds. Because nothing is satisfying when they eat, they stop eating. They lose weight. They lose their muscle. They become weakened. These two concurrent toxicities really become very significant in an elderly population who is already quite frail. So we watch them very, very closely. And sometimes we decide that using a hedgehog inhibitor is just not worth the risk as the benefit. And so we would advocate giving these patients immunotherapy instead. They can also get pretty severe muscle spasms, which we treat with calcium channel blocker amlodipine. Hair loss may or may not be significant depending on whether you're a man or a woman, but it can be complete, which again is problematic for most patients, especially since we tell them that this is not chemotherapy. And this is a response. Patients respond very, very quickly. This is another one of my patients, very large ulcerating basal cell on their scalp. Here you go, week 8, and here within 3 months, it is completely healed over. In order to confirm that these have fully healed, we do scouting biopsies to prove that there is no residual tumor. And these are just some waterfall plots to show you how quickly these tumors and how durable those responses can be. This is for patients who, again, had progression after hedgehog inhibitors. They were offered immunotherapy with cemiplimab. Here you can see a very large fungating area that after just 18 weeks, was very well controlled. And again, here on the bottom, right cranial basal cell after 9 weeks. And again, these patients heal up really beautifully and don't undergo a whole lot of toxicity. So my final topic tonight is Merkel cell carcinoma. These carcinomas are exceedingly rare. They happen much more commonly in an elderly population. And they are synonymous with what we look at as small cell lung cancer. They're small round blue cells that occur in the skin. And unlike basal cell and squamous cell, they are exceedingly rapidly growing. So this is a Merkel cell. Merkel cells many times get mistaken as pimples or cysts and go undiagnosed until they grow very quickly and then are biopsied. So the characteristic appearance is AEIOU. So they're asymptomatic, they just pop up. So patients think, oh, it's a pimple, it's nothing. However, they grow very quickly over a course of days to weeks. Common in the immunocompromised patients, patients over 50, and patients with excessive sun exposure. How do we treat them? Well, initially we try to operate on them, and then we give them adjuvant radiation. 95% of our patients will be disease-free for some interval of time. However, even with smaller lesions, these patients have recurrence about 50% of the time. If the lesion is large, patients will undergo a sentinel lymph node biopsy as well in order to determine if they've got nodal spread. This was the dismal landscape of this tumor less than 10 years ago. And you could see we gave patients chemotherapy. We used to give them what we call sandwich therapy. So they'd get a little bit of radiation, they'd get a little bit of chemotherapy in the middle, they get a little bit of radiation. And so you could control their disease. However, it came back very quickly. Because these are also tumors that are UV damaged, we decided to take a look, and sure enough, they have a very high tumor mutational burden. And so they are very responsive to immunotherapy. And these are the 3 immunotherapies in humans that are active in Merkel cell carcinoma. And I thought it was just quite appropriate that we have the angry attacking dogs for our aggressive picture. And so here we are in this is 2021 when all of these agents were approved for metastatic Merkel cell carcinoma. And again, the slide that we showed you on top was 2016. And here we have immunotherapy. So 60% of our patients now survive metastatic or locally advanced Merkel cell carcinoma, which is so much better than just 10%. But we're not there yet. There's still much work to be done. And so basically, how does immunotherapy work and why does it work? Well, we try to get T cells to become active and recognize tumors as being things that are foreign, not and things that are not self. And so how do we do that? Well, looking at this side of the slide, we have activating receptors on the T cell that if we activate them will cause T cell stimulation. However, we have on this side the inhibitory receptors where if we block CTLA4 or block PD-1, we block these inhibitors, allowing T cells to become active. Very, very effective in many malignancies, especially the cutaneous malignancies. So this is just a cartoon really showing how PD-1 pathways work. Very complicated slide, but I'm going to pretty much break it down to how I explain this to patients. Pretty much everybody, well, I shouldn't say that. Most people have seen Independence Day, or if you haven't seen Independence Day, you've seen Star Wars. So think of the cancer cell as the alien ship or the Death Star. It's got this protective shield around it, and it's up to the T cells to find a way in to get to the center and kill the cell. So what does immunotherapy do? Immunotherapy, by binding the receptors, puts holes in that protective shield around the tumor, and then you get an upregulation of your T cells that are now stimulated. So you've got all these fighter pilots that now have holes in the protective shield where the T cells can now get in and kill the tumor. I hope that gave you a good visualization because that's really how it works. It's just that simple. But, you know, in medicine, we like to make things difficult, ergo this slide. Everything clearly has toxicities. PD-1 blockade can also give you toxicities. Depending on which toxicity depends upon the timeline. And so here you can see the most common and the earliest toxicity we deal with is skin toxicity. Patients can get itching, they can get rash. Happens, you know, within right after the first cycle before they even get to the second cycle. They can get gastrointestinal diseases or diarrhea, colitis, enterocolitis. I like to also show the endocrinopathies because the endocrinopathies can happen over time. They can get pulmonary inflammation. All of these, I'm going to go to the next slide. All of these toxicities are inflammatory. So any itis can be a potential side effect of PD-1 therapy or any immunotherapy for that matter. So itis, dermatitis, myocarditis, hepatitis with an inflammation of the liver, pneumonitis, which we see when we treat patients with lung cancer. Those patients who are smokers already have pre-inflamed lungs, have a much higher predisposition to pneumonitis. Colitis, diarrhea, meningitis, very scary toxicity, very easily reversible. But if you do a spinal tap on those patients and you send it for flow cytometry, all of the lymphocytes that you see on your slides are all T cells. So fascinating to do all these clinical correlates to prove that you don't need antibiotics in these people and you need steroids. And so how do you manage them? Well, early detection, really education. If you educate the patient, you educate their family members to be able to identify the toxicities and call. No call is a stupid call. We tell them that if they're very intent on continuing with their therapy, which all cancer patients want to get treated on time, well, you tell them if they don't report their toxicity and they come into the office at the time of their next treatment and they have an untreated side effect, they're not going to get treatment. So by letting them know that you have to intervene early, you really do get management of these toxicities at an early stage, which is way easier than when they come in with grade 3 and grade 4 toxicity. And contrary to what we believe, how do we treat immunotherapy-related toxicities with steroids? Many times the steroids do not impact the efficacy of the treatment. You treat them early, you treat them when they're very manageable, so you can give a very short course of steroids and not impact your overall treatment effect. And so just in conclusion, in human beings, the best way to prevent cutaneous malignancies is really through prevention and education. Practice safe sun, use lots of sunscreen. Immunotherapy has changed my life, and it has really revolutionized the management of cutaneous malignancies because it has dramatically improved overall survival, because our effects are durable and patients can stop therapy, go back to having a great quality of life living off therapy. Immunotherapy is not without potential toxicities, but they can be manageable if they're identified and managed early. And my bottom line to every lecture I give is that, yes, we've come a long way. And yes, my life is much better than it was 20 years ago when we had that 10% survival or less. But we don't cure everyone, and patients still do die of metastatic cutaneous malignancies. And so until we are able to say we cure everybody, our goal, at least my goal, is to continue conducting impactful clinical research and continuing to move that needle. And I really sincerely hope that we can work together and move that needle for both our human patients as well as our animal patients. So thank you.
Thank you both very much. We'll take some time now to go through the chat. We've accumulated a few questions. And the first question is for Dr. Wong. We know that Stelfonta is on label for non-metastatic cutaneous mast cell tumors and non-metastatic subcutaneous mast cell tumors located at or distal to the elbow or hock. Do you think that Stelfonta could potentially be used on other tumors where the grade is not as significant for prognosis?
I don't think we know that yet. And I know that Stelfonta specifically right now is labeled for mast cell tumors. I don't actually know if we understand completely the underlying mechanism of it, but I would not use it in other tumors at this point because we just don't have any literature to support that.
Thank you. The next two questions will be directed towards Dr. Pavlick. Dr. Pavlick, for treatment of basal cell, and I believe the question is directed towards de novo basal cell, will retreatment with inhibitors work to prevent these tumors?
Again, you have to remember these patients are not going to be getting systemic therapy if they have resectable tumors. So if you have a patient who comes in with a large fungating basal cell, as well as other ulcerated or multiple basal cells or basal cell syndrome, yes, that will not only take care of the large lesion, but it will also manage the smaller lesions and hopefully prevent new lesions from occurring. It's very interesting. We have patients with basal cell carcinoma syndrome where they have just multiple basal cells. We try to treat them with hedgehog inhibitors. We treat them until they clear. We stop therapy. Patients can get somewhere between 6 months to a year off treatment, but then they start to come back because it's a genetic malignancy. And then we put them back on therapy. So it's a lot of on again, off again therapy. And we never really cured those particular patients. But it's nice to have multiple tools to do so.
Absolutely. And then the other question that I had for you, Dr. Pavlick, is do you recommend blue light therapy for precancerous lesions?
I am a medical oncologist. So when it comes to dermatologic recommendations, I really leave that up to my dermatologic colleagues. By time patients get to see me, their tumors are so much more advanced. But yes, that is something that we do have in our dermatologic toolbox. And many times when patients have multiple lesions, that is one of the options that they're offered.
Okay, thank you.
I
And then
have
the final comment, go ahead.
just one question to Dr. Pavlick. Have you guys seen pseudo progression with any of the immune checkpoint inhibitors? Because in the clinical trials for gilvatimab, there was evidence consistent with pseudo progression in some patients.
Um, in our PD-1, PD-L1 experience, exceedingly rare. However, when we use CTLA-4, which was the first immunotherapy that we got approved in 2010, absolutely you would see pseudoprogression. It was very scary because you just didn't know what to do. You know, patients grew new tumors, they've got new disease. And so we got used to telling patients that, you know, if you feel good and you look good, but the scan is good, well, then that's good. But if you feel bad and your scan looks bad, that's probably bad. But
Yeah.
if you look good and you feel good, but your scan looks bad, that means we just sit and wait, and it's just taking your immune system some time to just really give us a radiographic improvement.
Okay. That was one of the big topics that we had discussions about at our conference recently, was this idea of pseudo progression and how do we convince owners to continue to treat. And so I feel like what you just said is really important. And also, I guess we don't really understand the timeline to seeing resolution of disease for these patients with this drug yet. And so it was interesting to see in your talk, like how quickly things can go away once the drug starts to work.
Great. Well, thank you all for joining us tonight. Please click the link in the chat box or scan the QR code to submit your CE credit request. Certificates of attendance will go out on Wednesday, November 20th. Tomorrow's topic will cover melanocytic neoplasms, and we will be joined by Dr. Jed Wolchek and myself, and I hope to see you all there. Thank you.